Good evening, and thank you for attending AACP's webinar with Dr. Ingo Mahn, presenting Treating the Root Cause of Sleep Disordered Breathing. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 50 minutes, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. Dr. Mahn is the owner of Advanced Airway Solution, and AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE certificate of attendance within 30 business days. We hope you join us for Introduction to Therapeutic Injections for TMJ Issues, Headaches, Facial and Neck Pain in St. Paul, Minnesota on April 4th through 5th. This course will review anatomy, injectable materials, and hands-on techniques for injections, dry needling, and injection alternatives for patients suffering from orofacial pain and temporomandibular dysfunction. I would like to introduce our speaker tonight, Dr. Ingo Mahn. Dr. Mahn opened the doors to Natural Dental Partners in 2017, having previously founded Integrative Dental Solutions in Wisconsin in 1989. Today, his overall career in the dental world spans for over 40 years of clinical excellence and dedication. Dr. Mahn also provides personalized treatment for breathing disorders, sleeping conditions, and TMJ dysfunction. He studied at Spear Education Center and is a member of the American Academy of Dental Sleep Medicine. He also has experience in the use of epigenetic appliances designed to expand your airway to its fullest potential. His goal is to help his patients find lasting relief from their conditions instead of treating them just to minimize their symptoms. And he also enjoys educating his patients. And with that, I will turn it over to Dr. Mahn.
Thank you so much for having me on. I, love sharing this information, and I've had a long, interesting journey in dentistry. It seems hard that it's been that many years, but so I am excited to kind of share, what I've learned over the years. Just a little bit of background. I grew up in Germany, went to Marquette University back in the late 70s and early 80s. And I just kind of became a CE junkie. I always wanted to learn. I always was looking for a better way to do things. And, having been an early adopter of like the CEREC and cone beam technology, I ended up down here in Arizona quite a bit. And that's probably why I ended up eventually setting up shop down here, besides the fact that I got really tired of Wisconsin winters. I did the LVI thing back in the late 90s, and that's when I started kind of going metal free. And I really started looking more at being kind of having more of a health center practice. And that's what also prompted me to do a doctorate in integrative medicine, not to practice that, but more to communicate with my patients and the practitioners I was working with. And once I got down here, I founded a practice called Natural Dental Partners, and I have been doing an airway only practice since 2022. So I have a couple of associate doctors that are doing more of the restorative dentistry. And I'm fortunate that I was able to just build a really beautiful practice, literally a block from Spear Education. And I kind of got to do that with having already that blueprint in mind. And this is kind of my airway practice. And I was even able to, create a space where I have my dedicated airway assistant, being able to help me kind of fulfill that mission of doing airway dentistry. I know you mentioned you're gonna grab the questions. So if you have those questions, type them in the question bar. And I always like to, start my lectures with a question as well. And it's, how many of you screen for oral cancer in your practices? And I would venture to guess almost everybody's going to raise their hands if I do that. But interestingly enough, statistically, only about 11 out of 100,000 adults will develop oral cancer. So that means that if you have a practice of, 10,000 people, that means only one person statistically is going to present with oral cancer. You know, when I ask that same question, how many of you do you screen your patients for airway issues? A majority of the hands go down. And recently Howard Ferran in Dentaltown did a survey, and he found, in fact, that only about 30% of practices do screen their patients for sleep apnea. And so when you look at the statistics of how many people suffer from that, and this was from the Lancet Journal of Respiratory Medicine, and this was back in 2015. So I would venture to guess that if anything, that has probably gotten worse. So this isn't sleep apnea, but we're talking about sleep disordered breathing. But there's a large percentage of our patients that suffer from this condition, and this is just moderate and severe. And I'll show you that even a mild form of sleep disordered breathing can have really pretty consequential effects on our patient's health. So the goal for the presentation today is really kind of, talk about the problem and how we got here and why we as dentists should be treating these issues, how to recognize and diagnose them, and then ultimately how do we treat them at an early stage and not wait until these patients become full-blown sleep apnea patients. So one of the first things I always talk about is that we as dentists do not treat sleep apnea. And that's one of the fastest way to get yourself in trouble is to talk to your patient, say, I've diagnosed you with sleep apnea. I'm going to treat you for this. Really, I like the statement that as dentists, we're really treating the oral contributions to an impaired airway. And really, only a board certified sleep physician can make the actual diagnosis and and basically order the equipment to treat that. And I think that's actually, a good thing because a lot of dentists, I think this group is probably a little bit different than most dentists, is in that you're able to look beyond just treating the teeth. But there are a lot of dentists out there that should be treating these conditions that are just kind of very much kind of scared by the fact that, wait a minute, I'm getting into something that's really beyond the scope of my practice. And so the fact that we're just treating these oral contributions to an impaired airway, I think makes dentists in general a lot more comfortable. So why should we, I'm a why guy. Like, I always want to know, why am I doing this? Why are things going on? And so, why should we treat these issues in our practice? Well, first of all, I think you're seeing a lot more demand and awareness in this. You're seeing people like, Gary Brecka and Andrew Huberman and people like, just a lot of podcasts like Joe Rogan. They're talking about sleep apnea and breathing issues. So, patients are coming to our offices and are asking those questions. And you already saw from that first graphic, one of those first graphics, that we do have a lot of patients suffer from this. So a large percentage of our practice, we do have those patients that are suffering from those issues. And especially with this group, there's a huge association between sleep disordered breathing and pain. I was just at a conference called Transform Dental Sleep, and that was a really a recurring theme of how you really can't separate pain and TMD from sleep and how closely those two issues are related. And ultimately, we have those patients in our practice that really do desperately need our help. So once you see what the consequences of sleep disordered breathing are, you really do have to ask yourself, how can we as conscientious practitioners ignore that condition? And a little while back, I wrote a little booklet and I came up with this concept of like a health pyramid, kind of like the food pyramid. And everybody, when they're trying to get healthy, they're kind of doing all these different things. They're looking at, like, what kind of therapies can I do? What kind of supplements can I take? What other things can I add to my repertoire to make myself healthier? And yet things like sleep and breathing and oxygen, which are, to me, the very foundation of our health, often get overlooked. I think the airway and breathing issues kind of fall into, I guess you could almost call it like a medical no man's land where, doctors tend to think anything north of the neck, dentists and ENTs have covered and dentists and, tend to think that doctors have it covered. So patients kind of fall through the cracks when they're trying to get healthy. So just from, all of the different studies that have been done, there's been a lot of associations made with sleep with all of these different conditions. Everything from hypertension and anxiety to chronic fatigue, loss of libido, just all kinds of conditions. And I just remember early on studying with Dr. Jeff Rouse, who now teaches at Spear Education. He made a statement. He said, when I see a patient with a problematic health history, my first reaction is prove to me that it's not an airway issue. And at the time, that seemed like a really bold statement. I'm like, really? Like all these things are related? And um, when you start digging, you find out, the research shows that he's absolutely right. So I started, if you want to go into PubMed and put in sleep disordered breathing, and you can kind of put in, I guess, the condition of your choice, and you're going to find that there's a connection being made between sleep disordered breathing and that condition. So, for example, fibromyalgia, as a natural dentist, I tend to get a lot of people showing up with that type of diagnosis. Well, they were able to show that sleep deprivation in healthy individuals can cause symptoms of fibromyalgia. And it used to be the thought process was, well, these people are in pain, so therefore they're not sleeping well. Well, they're actually finding out that poor sleep precedes pain and predicted pain. And they were able to show that if you kept a group of people from reaching deep sleep for even a matter of 2 or 3 days, that you started getting all of the symptoms of fibromyalgia. Um, Same thing with depression. Patients with OSA present with sleep problems, um, and depressive patients can present with the same symptoms. And that's important because many of these symptoms overlap. And so they're cautioning doctors that they shouldn't just make a diagnosis of depression and be careful in treating that because they're so similar. It turns out that a lot of the medications and treatments used to treat depression actually end up making the sleep worse. So it gets to be kind of this vicious cycle. And you see that a lot with different things in sleep, is that whatever makes sleep worse, that in turn makes the condition worse, which in turn makes the sleep worse. And so these poor patients, if nobody's looking at the sleep, really kind of fall into this cycle where nobody's able to help them, and they're really frustrated. Same thing with immune function. Definitely something that we're much more conscious about these days, and it shows that OSA has an impact on cellular immunity. Uh, Hypertension, that's something we see quite a bit in our practice. Patients are coming in, they're trying to get off their blood pressure medications. They're finding that their blood pressure medications are becoming less and less effective. And so, we talk to them about proper nasal breathing and nitric oxide and all the benefits of nitric oxide. Nitric oxide has a great vasodilating effect. It's important in facilitating the transport of oxygen from hemoglobin into the cells. And it also has some antimicrobial effects. So these people that are chronic mouth breathers are not getting the benefits of nitric oxide production, and as a result, seeing much poorer health. If uh, if you have any interest in this, by the way, this is Nathan Bryan. He's one of the really premier researchers on this, and he did a great little, it's about an hour webinar. You can go on this. If you Google full script nitric oxide, it's going to come up, and you can see it in YouTube. And he does a really nice job of explaining all of the kind of the ins and outs of nitric oxide. Again, a couple other conditions. OSA patients are more likely than non-OSA to develop type 2 diabetes. And how about this? Snoring is associated with the development of diabetes. I mean, who would who would have guessed that connection? Um, Here's another one that we see quite a bit in our practice where patients are coming in and are saying, you know what, I'm struggling with my weight. And if you saw what I did and how I ate and the things I was doing, you think I'd be shedding the pounds like crazy. And instead I'm barely breaking even or I'm losing ground. And it turns out there are actually a number of connections between sleep and poor sleep and weight gain. Everything from hedonistic eating, which is the poor food choices that sleep deprived patients are making. So they've actually shown in studies that when people have had a poor night's sleep, that they make poor food choices. How it affects our appetite suppressing and stimulating hormone, the cortisol level. So when patients are in bed and they're in that fight or flight state, that high cortisol level, how that affects blood sugar and ultimately weight gain, and even improper breathing. Um, in the book Breath, James Nestor talks about how they really consider the lungs to be the weight regulating mechanism in our bodies, having more to do with the balance of CO2 and oxygen. But it shows that breathing is very important in all of those aspects. So, generally, what do we look for in sleep apnea patients? I mean, generally, we've always kind of thought of that sleep apnea patient as that middle-aged, overweight guy, with a neck like a linebacker. And we very rarely think of the younger, fit female or male patients that could be suffering from sleep disordered breathing. And in fact, there's a condition called UARS, upper airway resistance syndrome, that is kind of called the disease of young fit females. And so that's really comes down to not just the fact that we're we're having these apneic events, but it really comes down to resistance and increased effort to breathe. And the problem with this is that it puts our body into this fight or flight state. So essentially, I consider that our bodies are very intelligent. So when there's an obstruction to airflow, it kind of goes into this immediate, okay, I've got to figure out what to do here, and puts our bodies into that fight or flight, which ultimately causes increased cortisol levels and results in inflammation. And if you look at all of the different kind of conditions that people are battling today, a lot of them are inflammatory based. So I kind of like this slide. This was a National Geographic picture of the year, and it's this little marmot about to get eaten by an Arctic fox. But that's exactly what our bodies are going through when there's restriction to airflow. It just creates this uh, very strong response, survival response in our bodies, and that's going on all night. The fight or flight response is something that should just be going on for probably a few minutes per week. And instead, patients are laying in bed all night in that, having that same kind of a physical reaction to that stimulus of having an obstructed airflow. So the good news is that the dental office is actually the ideal place to screen for these patients because fortunately, or I guess for dentists, a lot of the signs of sleep disorder breathing manifest themselves in the oral cavity. And so, we're in a very unique position as dentists that we get to see our patients twice a year, whether they're healthy, whether they're sick. They come to our offices and we get the opportunity to see those signs and symptoms, and we can correlate them to their health history. So not only, are we seeing what's going on with them breathing wise, but we can now say, hey, look, here's your health history. These are the results. And so we can take that opportunity to educate our patients. And a big part of what we do is educating our hygienists because they've kind of got their, they've got their undivided attention while they're cleaning their teeth. And our hygienists get to spend way more time with patients than really any doctor that's out there. And obviously even ourselves as dentists, we're usually popping in. So I spend a lot of time educating my hygienists on how to spot these signs and symptoms and talking to our patients about that. So what are some of the oral signs of sleep disordered breathing? Well, clenching and grinding are probably some of the most common. And of course, for years, I remember being taught that the clenching and grinding is uh, due to interferences and bite issues. And I spent countless hours equilibrating patients to try to remove these interferences that that were going to result in our patients clenching and grinding. Well, it turns out that the clenching and grinding has actually very little to do with with bite issues. And it's much more closely related to a collapsing airway. There's a reason why our patients will grind, or a lot of them at least will grind through their night guards. Obviously, their teeth aren't touching, but yet they're still doing that clenching and grinding. And we're seeing the results of that. We're seeing the wear facets, the broken teeth, the tori. Uh, and that's why when I look at an x-ray of a patient, especially you get a female patient, you're looking at this panoramic or cone beam scan, and you're going, okay, you've got excellent bone level and you've obviously taken pretty decent care of your teeth over the years. So why are you missing, number 19? Why do you have an endo on number 3? Why do you have 4 crowns? And it really turns out that some of those forces that patients are putting on their teeth at night are drastically higher than what they can do during the day. So this was a little device at one of the sleep conferences I was at. It was a 2-day conference, and the rep for this company was there. And this GemPro is basically a device that measures the forces of bruxism. And so we all took one of these home, and the last thing you do with this device is you bite down as hard as you can, and then you go to sleep with it. Well, it measures the forces of nighttime clenching and grinding, and it turns out those forces can be 3 to 4 times what the maximum biting that you can do during the daytime. And when I saw the numbers, I'd never seen that before, and I was shocked. I was like, okay, well, that makes sense. I mean, we all have patients that break things, and you're like, okay, how in the world did you break that? You couldn't have done this just from chewing or biting. You must have, you must have been biting on rocks or chewing on something you shouldn't have. Well, it turns out there's a feedback loop that's in place when we're awake that goes away in once you hit stage 2 sleep. And so you have these patients that are putting incredible forces on their teeth at night. And so that's something that we need to be conscious of, especially if we're restoring teeth, if we're putting in implants, if we're putting in, especially with all of the ceramic restorations we're doing these teeth, we really have to be conscious of the forces people are putting on their teeth. Um, we look for crowding. We look for the shape of the arch, the shape of the palate. Those are all indicators of how the tongue is functioning and how the the tongue, which we consider to be like a little orthodontist in your mouth, that needs to be doing its job. It needs to be coming up to the roof of the mouth. It needs to be pushing out. And if the tongue isn't doing its job, we see the results of that by looking in the patient's mouth. Scalloped tongue is a sign of obstructive sleep apnea. Even TMJ pain, and that's obviously something that we're really conscious about. When you see again the forces that patients are putting on their teeth at night, that can definitely be one contributing factor to TMD. So it's definitely something that we can't ignore. And we also look at tongue ties, because that has to do with how the tongue is and whether or not the tongue is able to function properly. And then we'll also look in the back of the throat and get a Mallampati score and kind of see how much space there is for the patient to breathe. Even though we generally we obviously don't want the patient breathing through their mouth. This is still a good indicator of how the patient is functioning. So we look at the signs, but we also have created this form that allows patients to kind of fill out some of the symptoms that they have, because these are things that you're not going to get from your patients from their a conventional medical history. And a lot of times they won't even remember or think about these things. So it's really interesting when we started using this impaired mouth form, we really started to learn a lot more about our patients, and it really kind of made them aware. They're like, oh yeah, you know what? I kind of forgot that, I do get up 3 or 4 times in the middle of the night to go to the bathroom, or I've had more neck and back pain lately. So we're able to you know, get patients to fill these out and make them aware. But more importantly, as we're doing treatment, these are the patient's pain points. These are the reasons why they end up choosing to go forward with treatment. So, if they're telling us that, they're waking up in the morning feeling like they haven't gotten a good night's sleep, or they're exhausted in the afternoon, or they're whatever symptom they're having, we want to make sure, and we'll get into that later, that as we're doing treatment, that we're addressing that part, because ultimately, no matter all of the different diagnostics that we do and all the different data we gather, that's irrelevant to our patients. Ultimately, they're going, hey, I came in here because I'm exhausted all day long. Am I feeling better as a result of this treatment? So, how did we get here? How did we end up with all of these sleep issues that maybe in the past, weren't so much of a problem? Well, it starts early. You know, there was a period when medical doctors were telling moms, hey, bottle feeding is just as good as breastfeeding. And I probably consider that maybe the single dumbest statement in the history of medicine, uh, because that's really where our journey to health starts. And this was from the Journal of Functional Orthodontics, 25 years ago. They showed, and that's what I always thought. I was always thought, well, the breastfeeding benefits come from the nutrition in the mother's milk. Well, it turns out that the true orthopedic benefits of breastfeeding suckling deserve more definitive attention, because it's early preventive functional jaw orthopedics, because those forces impact the jaw during the early rapid growth period, and that it really forms the airway. And instead of something like bottles and pacifiers that deform the jaw, the breastfeeding is actually a process by which the airways and all of the structures of the head and neck start to properly form. So, we're also dealing with not just poor nutrition, but also a change in the consistency of our diet. And, we're seeing more and more patients that are allergic to a lot of foods that they hadn't been allergic to before. So in the past, it was pretty much if you address maybe a gluten and a lactose allergy, you pretty much had everything covered. Well, now we're seeing a lot more patients coming back from having allergy testing done, that they're allergic to foods that you would never think they would be allergic to. So that's something to address, because if they're congested and they can't do proper nasal breathing, that's going to impact their treatment. So how do we address this problem of underdeveloped jaws? Well, one of the first things I kind of found out was the mandible isn't the problem in most cases. And that was kind of a shock to me. So in most cases, it turns out the problem is an underdeveloped maxilla. And so I had spent, I probably spent I would say a good 7 to 8 years going to a lot of different airway conferences and studying with all kinds of different practitioners. And guess what? Nobody ever talked about the maxilla being the problem. We were all talking about what's going on with the mandible. How do we move the mandible forward and keep the tongue out of the airway? Well, one of the first people that really changed my thought process was James Nestor. And if you haven't read this book, I would recommend it for a couple reasons. First, it has a lot of great information. I was actually kind of upset the first time I read it because I go, okay, I've been studying airway issues for all these years now, and here's the first person to really talk about why are we here. The other reason is a lot of the patients that are coming to our practice are coming because they've read this book and they're aware of this. So um, it does have a lot of great information. He writes in a very entertaining style, but he really gets to the whole basis of why we have these underdeveloped jaws. And this is from one of his presentations. And if you once you become aware of this, one of my mentor, Dr. Liao, he said, I'm really giving you new eyes. I'm not teaching anything new. I'm just giving you new eyes so that you'll recognize these things. You're going to start seeing this kind of a facial profile, and all of these different things become associated with having a retruded mandible. You're going to get crowded teeth, deficient nasal cavity, that entrapped mandible a lot of times can cause symptomatic joints and ultimately a constricted airway. And it kind of like drives my family crazy because we'll be in an airport and be like, look at this guy, he's an airway patient. And first they laughed at me, but now they're doing it. And even when I'm watching TV, I'm a Formula One fan, and this is a guy named Sergio Perez, and he didn't do so well last year. And I just when I saw this image of him on TV, all I saw was, okay, he has a retruded mandible, and if I can fix his airway, he probably he probably could have done a lot better last season. So, once you know about this, the oral signs and symptoms and some of the other features of that we see in sleep disorder patients, you really start to recognize it pretty much everywhere. So that's really the issue, is that our skulls and our jaws are shrinking, and um, and there's just less room for the tongue. And down Enloe, there's a study showing that the width of the gonial angle is directly proportional to the size of the airway. And so we used to have a taller, wider symphysis and wider gonial angles, and we just had more room and a bigger airway. So that's kind of where we're at. We just have less real estate to work with. So the gold standard for sleep apnea is, of course, the CPAP, and we're very careful in our documentation that we document, that we tell a patient that that this is the gold standard and that we're not treating sleep apnea. And of course, you know, we all know that patients in general do not like. I think I've talked to one patient over the years that says, "Oh, I love my CPAP," but other than that, it's not something people want to do, and if they have it, they're hoping to be able to get out of the CPAP. And so, of course, we in dentistry, have a solution of the mandibular advancement appliances. And of course, we know how they work. They essentially just, prevent the jaw and the tongue from falling backwards into the airway. And so, I did my share of these appliances. I saw a lot of patients coming from other practices. And what really bothered me was, some of the side effects that I was seeing with these patients. So that's really what kind of prompted me to kind of keep looking and seeing if I could find something that would be more along my philosophy of fixing the root cause of the problem. And that's something I've kind of always over the years been kind of a common theme in my practice. I always want to know, I want to fix the what, I want to fix the why. So the first step, that we do in our practice is we always want to determine the severity and the extent of the problem. So some of the diagnostic tools that we use in our practice that um, um, obviously are more common now and a lot of us have in our practices is a large field of view cone beam. Um, it gives us a lot of information. I don't use this necessarily for diagnostics, but when I'm working up one of these airway patients, I tell them, I'm like, I'm kind of playing Sherlock Holmes here. I'm trying to look at it. I'm trying to get as much information as I can. And it does turn out, this patient has what a minimum cross section of 58 millimeters squared. It turns out there's a, a fairly limited correlation between minimum airway cross section on a cone beam and an AHI, which is the apnea hypopnea index. Um, it was interesting. I was at a sleep conference and a dentist from Dallas who has a very large sleep practice said that he sent 400 cases to a statistician and he sent them cone beams that showed what the minimum cross section was, as well as their sleep study with the AHI. And they actually found that he said no correlation. I don't know if there's no correlation, but I would agree with the fact that there's very limited correlation. So just because you see a large minimum cross section on a cone beam doesn't mean that that patient isn't going to have a problem. I had a patient the other day. He grew up in Bavaria. He was a mountain guide and skier, and his minimum cross section was 606 millimeters squared, but his AHI was almost 30. You would think with a minimum cross section of 600, that's like a 10-lane freeway going down to the lungs. You're like, there's no way this guy has any kind of sleep issue but yet he had a highly collapsible airway that resulted in him being a sleep apnea patient. So when I look at a cone beam, I do get a lot of information. One of the things is I look at the shape of the airway. Um, I always I like to compare this to, this is something patients understand. I say you have a fire hose airway. A fire hose obviously lets a ton of water through when it's pressurized, but as soon as it loses that pressure, it folds flat, and that's kind of what's happening to their airway. As soon as they're laying down, going to sleep, it doesn't take a whole lot of pressure from the tongue to collapse that airway. Um, One of the other things I look at is I look at the position of the hyoid bone. If you draw a line from the bottom of C3 to the bottom of the mandible, if that hyoid bone is below that line, that's about 80% diagnostic for obstructive sleep apnea. So when I look at these x-rays, it's just one of the things that I take a peek at, and when I see that, it just gives me an indication that I'm going to have to dig further, and there's a good chance that this patient is going to suffer from sleep apnea. Probably other than my eyes and ears and talking to patients, as far as a diagnostic tool is the home sleep study. And those have fortunately really gotten so much better over the years where we're really able to get some good, valuable data now. Sometimes people go, well, I think I sleep pretty good. And I said, well, you know what, if we're not measuring, we're guessing. So let's go ahead and figure out what's really going on with your sleep. So before we start treatment, we spend a lot of time compiling a lot of different information. Like I said, I'm playing Sherlock Holmes. I'm trying to figure out all of the different things that are going on. Uh, we don't we used to take more cephalometric X-rays. We don't do that quite as much. We have a pharyngometer and a rhinometer where we're measuring the collapsibility of the airway. We're using our impaired airway form. We're taking optical scans. We're taking photographs. We're doing posture photos. So we're trying to gather, again, as much information. And it's really nice because my airway assistant puts this into a really nice consultation form. So we have a template for this. Yes, my assistant takes all of that information and she puts that together. So when we sit down with the patient, we can really, present them with a comprehensive analysis of what's going on with them. And like I said, or like you see there, managing expectations is critical. This appliance is designed to create strain and allow the cranial bones to move. And Dr. Balfour always said, without strain, there is no growth. And that's really what we're missing in modern society. It started with when we started cooking our foods. It got worse when we started microwaving, and now even people who are into the concept of being healthy are they might be getting the nutrition, but they're not getting the strain and the input our body needs. So that's really the concept of epigenetics. It's really how our DNA is expressed. So this is from an old book, and they found these twins. This was in the 1930s in Ireland, and identical twins. He apparently liked sugar and junk food. Apparently, they already had junk food back in the 1930s. But look at the difference. So they had the same genotype, but look at how differently their DNA gets expressed. So the three main mechanisms of action of this appliance is really the remodeling of the facial bones. They tone the muscles of the airway. One of Ted Balfour's favorite sayings was, wearing this appliance is like taking your tongue to the gym. So it forces your tongue to come into the proper position. And because it has to lift that extra 4 or 5 millimeters, it now helps tone the genioglossus muscle, which is, considered to be the main airway dilator muscle. And then it also just downregulates our autonomic nervous system. Think about what happens as we chew. From an evolutionary standpoint, our bodies are saying, okay, you're not being chased by anything. I have to get ready for digestion. So it just kind of calms that whole autonomic nervous system. So we're really trying to turn kind of that fight or flight into a more relaxed state. And then a big thing to remember is, in cases of severe and central apneas, we still will continue to work with ENTs and sleep physicians. Again, I don't want to be doing oral appliance therapy on somebody who could be potentially having a stroke or a heart attack. I mean, I don't ever want to have that conversation with an attorney. Like, what were you doing for this patient? Like, are you kidding me? So that's why we make sure that we work with all of these specialists. Just real quickly, finishing up here, the treatment sequence is we take the records. Generally, about a week or two later, we have the consult assembled and we sit down with the patient. When they decide to go ahead, it takes about 2 to 3 weeks before we can insert the appliance. And then we usually have them wear the appliance for a couple weeks. And at that point, they come back because they usually don't even know what questions to ask when they first get it. And then we just monitor them. They come in about every 8 weeks, and we're more or less just checking, are the appliances fitting properly, and are they progressing? So our goal for airway treatment ultimately is always to improve patient symptoms. And we actually put that in here. We have their three main concerns, and we really monitor, say, hey, if that problem was a 10 when you started, where are you now? And we're also just making sure that everything is that we're not causing any problems, that we're not causing any changes in the bite. We're also making sure that all of the specialists that we're recommending they work with are being seen, and that things are being followed up with. So improve patient symptoms. We want to make sure they're 100% nasal breathing, good tongue position. We want to make sure we eliminate all the cofactors, and ultimately enlarge and tone the airway. And to do that, we're going to work with whoever we have to work with, and that's everybody from sleep docs to myofunctional specialists to allergists, chiropractors. There's a group called PRI, Postural Restoration Institute, chiropractors and physical therapists, and also physicians and naturopaths. And ultimately, I love Steve Carstenson's quote. We just want to open airways. And so, that's what we're hoping to accomplish with these appliances, because we don't want to put a young female in her 20s and 30s into a mandibular advancement appliance if we can treat the root cause and just really help improve the health of that patient. So I know I had to go kind of faster at the end. I had so much information. Usually I do like a whole a whole day course on this that goes from 8 to 5. So I try to get as much of that information into the presentation. If you do want to contact me personally, I'm more than happy to, answer your questions. This is my personal email, and so yeah, so that is it. So I'll turn it over and see if there's any questions.
Awesome. Thank you so much. A lot of great information. We do have some questions, and we'll get through as many as we can. And then
I know
thank
I
you.
got right to the end there, so I
No,
apologize.
you're okay. It was a lot of good information, so we appreciate it.
Okay,
Uh,
good.
let's see. A couple of questions here. Is a radiologist always reading the CBCTs, and is an MD always doing the diagnosing with that info?
So no, the nice thing about this treatment is we're not treating sleep apnea. We're treating the really just we're really just toning the airway and treating the contributing factors. So to do this appliance, we don't need a diagnosis of sleep apnea. And that's also one of the downsides is that these appliances aren't right now covered by insurance. I've tried to be very efficient in how I deliver those so I can keep the cost really low because I know some epigenetic airway programs, dentists are having to charge, upwards of $10,000. So just to give you an idea of my fees, we're charging closer to $6,000 for the Homeoblock, and in conjunction with the clear aligner therapy, I'm only charging about $8,500 just because I can deliver that clear aligner therapy so efficiently. So I'm trying to keep the price almost still within that clear aligner type price range.
Great. And are these HSTs being read by a sleep doc? Dr. Hafs believes that states require the OSA diagnosis to come from MDs.
Yeah, so that's again, we're telling our patients we are not making a diagnosis of sleep apnea for them. So we're just telling them that there are some things going on structurally that are affecting their airway, and that's what we're treating. So we're very specific about the fact that we're not making a sleep apnea diagnosis. Uh, if the AHI, so we're kind of, think of it like putting a blood pressure cuff on one of our hygiene patients. We're not making, when we see a high blood pressure reading or anything on that, any information we get from that, we're not making a diagnosis. We're really using that as a screening tool. And so if we suspect, if we're seeing, okay, your AHI is 25 or 30, at that point we say, hey, we're seeing a problem. You need to go see a sleep physician. But we're not making that diagnosis. So we don't need that to be read. But in some cases, we're working with those specialists to get that diagnosis.
Great. What is the point of asymmetrical occlusal contacts?
So it is to create strain in the system. We were at one point we had a diet that had the consistency of beef jerky. So when you create that strain and that one-sided chewing, that's what really stimulates the bone growth and the formation of our cranial structures. And because our food has just over the years gotten consistently softer and softer, we're essentially turning into two-sided chewers, and that's what's resulting in these underdeveloped maxillas. So by creating that strain, we're essentially just replacing the missing hard food in the diet.
And how does that asymmetry affect the occlusion long term?
So we're not seeing any changes in the bite. Our patients, when they're taking their appliances out in the morning, and I wore the Homeoblock for about a year or so, I would find that, maybe your bite just feels a little strange for maybe literally a few seconds versus, what patients are describing with mandibular advancement devices. So they're really only occluding on that every time they're swallowing. So the appliance has more to do with establishing proper tongue position. And but the strain that's created is not, it's we're not getting any, say, super eruption or any intrusion of teeth with this appliance.
How do the unbalanced contacts affect the TMJ?
In most cases, we're seeing, we are careful. Obviously, TMJ is one of the things we look at as far as when we're doing the treatment. Uh, in most cases, we're seeing relief of symptoms because we're really the man, we really are allowing that the entrapped mandible to come down and forward. So in a lot of times we're actually getting uh, resolution of TMJ symptoms. Now, obviously, TMJ, there's a multitude of things that are contributing to that, uh, and we take that into consideration. But we're seeing a lot of people who are having, who have like, just because they have they come in, they say have tight muscles and tight joints, we're actually getting relief of symptoms by allowing the jaw to come down and forward.
Okay. And what is your protocol to screen and diagnose TMD?
Um, I mean, we're basically, looking at cone beam images. We're basing it mainly on symptoms. So if they have symptoms, we're looking at the joints radiographically. If they have, if if there are issues that we suspect are beyond just uh, something related to the sleep, there's a TMJ specialist that I work with, and they do a lot of times further imaging and other diagnostics, uh, because yeah, the TMJ can get obviously very complex, and so again, it's like, you have to kind of find out what's going on and decide, is that something I'm willing to treat, or is that something I need to work with another specialist?
And you touched on this at the beginning of your presentation, but how accurate is the relationship between scalloped tongue and sleep apnea?
Um, You know, that's a good question. I don't know if there's been any, specific studies done, but in almost every single case where I've seen a scalp tongue, it's been very, very closely related to sleep disorder breathing. So I can recall a case where I saw a scalp tongue where the patient didn't end up having some kind of a sleep issue.
And then a couple of questions on the Homeoblock appliance. Would the Homeoblock appliance be appropriate for a patient with TMD? And are there any contraindications for the Homeoblock specifically with TMD?
Um, Yeah, I mean, absolutely. Like I said, if they are symptomatic, then that's one of the first things we look at to see, we don't want to be putting patients into Homeoblock if there's some structural or other TMJ issues. So that's something that we screen for. Uh, Really, the only contraindications is you do need molars, and you want to avoid doing this in periodontally involved teeth. But as far as the TMD goes, we're basically just screening for the symptoms, and then if we're seeing structural problems, then we're working with someone who's maybe more equipped to deal with that.
Okay. Wonderful. Well, I think that wraps up the Q&A portion. I want to thank you again so much for your time tonight, Dr. Mahn. Great information. And recordings of the presentation will be sent to all registered attendees within 10 to 14 business days.
Well, thanks
All right.
for having me on.
Yes, thank you. Have a great night.